Welcome everyone to the Thursday, January 14th, 2021 COVID-19 clinical rounds. We're focusing today on rural and frontier vaccinations. My name is Richard Hunt. I'm an emergency physician who serves as Senior Medical Advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer, real-time sharing of COVID-19 challenges and successes. If I'm a clinician caring for COVID patients, the clinicians I want to learn from are those with the most experience. This is a voluntary public-private collaboration. Thanks to the multiple professional organizations who have collaborated on these rounds. They are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges with other clinicians. Thanks to the National Emerging Special Pathogen Training and Education Center, NETEC, for their support with these rounds. NETEC's webinars complement these Project ECHO COVID-19 clinical rounds. Thanks to Project ECHO, Dr. Struminger, and his team for the peer-to-peer learning platform we use for the rounds. Upcoming ECHO COVID-19 clinical rounds are all US noon Eastern time. Next week's schedule will be different than usual. Monday, January 18th, EMS rounds will be canceled due to the Martin Luther King holiday. Tuesday, January 19th, we will have COVID-19 clinical rounds on critical care. This one will be focused on prolonged ventilator management in the emergency department. Wednesday, January 20th, the outpatient therapeutics mini-series usually happens on Wednesday. That's canceled this coming Wednesday due to Inauguration Day. Thursday, we will have COVID-19 clinical rounds for the emergency department. And to just summarize all that, I went through the detailed schedule, but to summarize, rounds are canceled except for next week, except for Tuesday's critical care and Thursday's emergency department. With the daily rapid changes, please pay careful attention to announcements that come from Project ECHO regarding the round schedule. ECHO, Dr. Struminger, please, I'm going to turn this over to you.
Great, thanks, Rick. Welcome, everyone, and special welcome back to Ann Zinke. Looking forward to your talk. And just gonna quickly run through the usual logistic issues. So we love your questions and comments, and please keep them coming. Put them in the Q&A function at the bottom of the Zoom toolbar, and we'll be monitoring that and try to get to as many of them as we can. If any technical or logistic issues, mention those in the chat, and we'll try to help out there. Also, Rick will be asking a crowdsourcing question, and the chat is the place to reply. We are recording this session as we always do, and your attendance is consent to be recorded. Thank you for that. Dr. Zinke's presentation will be made available along with the recording of this session on the HHS ASPR Clinical Rounds website. We'll put a link in the chat to that, and hopefully we'll have the recording and the PowerPoint up within a day or two. Also, we're offering CME and continuing professional development credits through the University of New Mexico, where Project ECHO is based. We'll put a link in the chat to the survey, and about 15 minutes before the end, it also should be in the announcement that went out today. Just a reminder that these learning sessions are focused on improving patient care and health systems and supporting clinicians. Please let's keep them apolitical and non-commercial. Thank you for that. And a brief word about data use. The data you share with us through the registration, through the polling, through the chat, we take data stewardship seriously and safeguard it carefully. We do share some data with Rick and ASPR. It's all de-identified. Also, Rick mentioned that NETEC, the National Emerging Special Pathogen Training and Education Center, is a partner in these rounds. They have a great webinar series. Yesterday, they did a webinar on navigating simultaneous disaster response scenarios. And all the webinars they do are recorded and archived on their site. And we recommend you check those out. They haven't put up a schedule yet for the next upcoming webinars, but I'm sure they will in the next day or two. With that, also just a reminder about this outpatient therapeutics mini-series that has been running since early December. Right now, it's focused primarily on monoclonal antibodies. Yesterday's session was a great one with colleagues at Mass General. As Rick said, next week we'll take the week off in honor of the upcoming inauguration, but we'll be back the following Wednesday, and we'll put a link to register in the chat for that. With that, let me pass the microphone over to Dr. Rosha McCoy with the Association of American Medical Colleges. Rosha.
Thank you, Bruce. Yes, just a reminder about this resource that is available. We're continuing to update from the Association of American Medical Colleges, the Coronavirus Clinical Guidance Repository. We just actually updated again today. There's some updates on ECMO eligibility, both from the University of Washington and from Mass General. And so please make sure you continue to check because we do have updates coming all the time. We actually, I think, updated this site 60 times. So it's continuing to be a really important resource, I think, for folks because it is open access and it really gives you an idea of what's going on around the country. We're hoping to add some vaccine information soon, so be on the lookout for that. Thank you.
Thank you, Rosha. So Rick, back to you for the crowdsourcing question.
Thanks, Bruce. With the emergence of all the challenges around vaccines, felt it appropriate to ask this question today for crowdsourcing. What innovation has most quickly increased the number of people receiving the vaccine in your organization or region? What innovation has most quickly increased the number of people receiving the vaccine in your organization or region? I hope there's something in here in terms of the responses that others can take and run with, because we need to get this into arms of people. I'd like to ask our panelists to please unmute themselves and briefly introduce themselves as we do in usual fashion. Let's see. Harry, I see the bear. If you're able to speak, and we know you got some audio problems and so forth, but if you could introduce yourself, that'd be great.
Sure. My name is Harry Seibold. I'm an EM and EMS physician from Helena, Montana, past state EMS medical director for the state of Montana, and currently on a COVID assignment in Odessa, Texas.
So thank you, Harry. Take care of yourself out there. Dave Gerstner.
David Gerstner. I'm with Dayton Fire Department in Dayton, Ohio, and I'm the regional MMRS coordinator for West Central Ohio.
Thanks, Dave. Dan?
Dan Gerard. I'm a registered nurse and a paramedic, and I'm the president-elect of the International Association of EMS Chiefs.
Thanks, panelists, for being on. And also, as I take a look, I got two EMS leaders on. One of the things that Sandy Schneider, who's usually on, she couldn't be on today, but she points out that has been actually really valuable with the rounds is the interdisciplinary nature of some real good cross-fertilization and discussion among disciplines, because yeah, it's overused phrase, but appropriate. We are in this together for sure. With that, it's really, I'm thrilled to have Dr. Ann Zinke back. She presented before, she's presented many venues, but in particular, we on rounds know we have a huge number of participants who are in rural areas, and it seemed more than appropriate to have Ann back to talk about rural and frontier vaccinations. With that, I'm going to turn it over to you. Thank you.
Great. Yeah, it's an honor to be here. So I'm Dr. Ann Zinke. I'm the Chief Medical Officer for the state of Alaska. And I'm also a practicing emergency medicine physician. So it's always great to be here with colleagues EMS, nursing, ED. This is my happy place. So it's great to have you all here. And I haven't gotten a chance to be at the rounds here recently. I think we're all busy, but I do miss them because it's a great chance to learn from you all. So thank you for the opportunity to be back. I just have a few slides today to kind of talk a little bit about where we're at in the state of Alaska with vaccination. I've started to not make slides with numbers on it because by the time I put them together, that was 2 p.m. and everything has changed. So I started to just go with more pictures because things just change really, really rapidly. But I'll talk through some things. And again, I really am happy to take any questions whatsoever people have in the state. So go ahead and go to the next slide, please. So this is Alaska. Sorry, Harry, but it is bigger than Montana, Texas, and California combined. A large state. I think sometimes people don't realize how big Alaska is. If you put it over the lower 48, we would essentially go from California to Florida. It is a really big place. And at the same time, it's winter. So I know it's super exciting to have these vaccines out, but man, winter in Alaska is not ideal timing for us. We're trying to get it out. Weather is a big challenge out here. And we have a lot of different systems of care, like the rest of the United States, in trying to get care out. So on this map, you can see the public health centers. And the reason I put this on is because it's a big part of our vaccine distribution plan. Alaska doesn't have counties, it has boroughs. Not everyone lives in a borough. Some people live in unincorporated communities. Many regions cover multiple boroughs and or multiple census areas. So it's hard to talk in any one of those terms in this state. And essentially public health is very much centralized at the state level, except for 2 independent public health, one Norton Sound, and then the biggest one is in Anchorage. But the rest of it is all really happening at the state level. So we are very much highly involved in coordinating all of the aspects that's happening with vaccine. We have public health nurses throughout the state, and you can see the different colors associated with it. And so it's kind of a hub and spoke model, excuse me. So you can see like Fairbanks region, there's all those kind of like hubs off of the Fairbanks region. Those are communities that they serve. The Aleutian chain is that islands kind of way out there. Those are mainly served from the Anchorage area. So some people live in those communities, but sometimes it's just a lot of flying back and forth between communities to see what that looks like and to be able to serve those areas. And then some, particularly up north, are grantees where we essentially fund public health efforts in those regions. And so a lot of our coordination is there. I would also just state that most of our regions are not served by FedEx and UPS, so you can't ship. And so as much as that direct shipment's great, you know, that little asterisk on the bottom of your Amazon cart that says do not deliver to Alaska or Hawaii, like that really affects the shipping and everything from peanut butter to vaccine, it matters for. So we have a really robust immunization program in the state of Alaska, children's vaccine program, where we use kind of a hub and spoke model where a vaccine comes into the state. We have a depot, we reprocess it, and we send it out to our hubs, and then they reprocess it and send it out to all the spokes from there. And so we really built our COVID vaccine team on top of that. And so if you go to the next slide, the next layer that we layered into here is the Alaska Native Health System. So Alaska Native people make up about 16% of Alaska's population. But for example, our testing, 50% of our testing is done at one of our Native sites for testing. So while it's a smaller percentage of our population, it's a big percentage of like the number of places that it's happening just because they cover such a broad, diverse area. As you can see, their map doesn't exactly fit the public health nursing map. I oftentimes think of like those old little flimsy, you know, PowerPoint sheets or those little, you know, sheets when you're in grade school of all the maps layering on top of each other. We have lots of different maps that we try to layer on top of the way that healthcare is delivered. But this one's another really important one, and this is kind of the Native Health System, and we have what are called THOs or tribal health organizations. We have 226 independent tribes in our state, and they are organized into 13 tribal health organizations. One represents Alaska Natives outside of Alaska, and the other 12 are up here. And then these are kind of the regions that they serve. So, you know, what I refer to as the YK or the Yukon-Kuskokwim Health Corporation, that's that kind of lower yellow. The Tanana Chiefs is that like really big blue area in the center. And so when we set up our entire vaccine plan, we did it in combination with them. So for example, our Healthy Alaskans 2020 and 2030 program, which most states have, we don't run it just as a state, we run it in partnership with the tribes. And so we have co-leads and at every level, and we actually have tribal and state goals that we try to meet all together and moving our way down. We felt like this was a better way to systematically build in that conversation and to make sure the structure was set up. So when we set up our vaccine planning team, we did the same thing. So we have co-leads for planning, co-leads for leadership, co-leads for communication, co-leads for operation, co-leads at every single step of the way with the Alaska Native Health System because it was such a critical part of actual delivery of vaccine. We also didn't know if we were going to get all the vaccine as a state, if they were going to get it separately, what was going to happen along those lines. We just wanted to be prepared to be able to be nimble no matter what ended up getting decided at a federal level. Ultimately, the tribes were allowed to be treated like their own jurisdiction. They do have a sovereign nation-to-nation agreement with the federal government. And the tribes were allowed to choose if they wanted to go with IHS for distribution or if they wanted to go for the state with distribution. It was a little unclear exactly what that meant. And I know many of our tribes really struggled with that conversation, but they really appreciated being able to have the choice and felt like that was really important. Ultimately, every tribe in the state of Alaska opted to come with the state to be able to get distribution out. And I think that's because of that partnership of kind of shipping and being able to work through. But their allocation is their allocation. So what they decided to do was to look at their population, and when they get their allocation in, they break it up by THO, by tribal health organization, and we'll do it just straight by population. So Tanana Chiefs gets X amount, or Arctic Slope gets X amount. And I often joke that we're the Amazon shippers of the IHS allocation. So we help to get it around, but they have slightly different priorities on how they want to use it in each of those regions in combination with the state. It has really allowed us to work together collaboratively in a very different way. So instead of sending like 1 vial or 3 vials, we're working in really small numbers for some of these communities. We can really combine efforts. We were looking at one town the other day. It's going to cost us $17,000 to get to that town once. And so, just the cost of getting there, you don't want to just do their 65 and older and then like come back with the next year and then come back with the next time because it's just super expensive. And actually that region down in Aleutian Chain, we haven't been able to get into for the last 4 weeks because of weather. So it's not that we don't want to get them vaccinated, it's just like we can't literally get in there. We have a really good weather window right now, so they're making all sorts of runs. And our normal process of having to request vaccine 72 hours beforehand doesn't work for them. So we just have like a separate way where when they say the weather, the depot, grab vaccine, and then they just go and they vaccinate the whole town. So we've had to really just kind of change the ways that we do it. They use state vaccine to go through the tiers, but then they use IHS to kind of augment that for, say you go to a community and there's 50 people there, being able to kind of do that 50 people within that community. So they've been able to prioritize, and they prioritize it slightly differently based on each of the THO. So again, like that Aleutian Chain area is really so transportation dependent. It's highly involved in there versus YK is a really big community with many communities without running water and sewer. They're kind of doing a different tiered process. It just looks a little bit different in each community overall. Next slide, please. So this is where we get into my favorite pictures because when days are bad and grumpy and I have lots of people yelling at me, I usually just look at what's happening for the vaccine distribution and it makes me much more happy. And it's really this amazing community partnership that's happening across the state. And so a couple pictures on here. So this one with the plane and the snow machine. So this was the very first bits of distribution that happened in the YK region. And they were getting just healthcare providers at that time. And many of these communities don't have nurse practitioners, physicians, nurses, physician assistants, and most of them have community health aides, which is a fairly unique, it's kind of like community health workers. It's just an Alaska kind of version of it. They're certified health workers who work in communities. It's within the tribal system. There are 4 different tiers depending on kind of their education. From the very beginning, we provided them with swabs and medium and education about what's happening with COVID. We've had some pretty remarkable stories of communities with, no running water and sewer who have had like an Abbott Now. One person showed up, was positive, maybe they had a relative who had to travel for emergency medical stuff into Anchorage and had picked it up. And just with having that Abbott Now machine and the knowledge of what to do, even if we couldn't get in to help them or they couldn't get anyone out, they were able to isolate and quarantine everyone who needed it and keep the outbreak to a very small number. And one of the communities I'm thinking of had no hospitalizations, no deaths, was able to get completely on top of the outbreak on its own, despite, really tough living conditions. Again, no running water and sewer, 10 to 15 people per household, many people at risk. So I really feel like when we can empower communities with the tools that they need, they can thrive and they can really accelerate. So they really prioritize the community health aides. We put them as part of that tier 1A in our grouping as part of our essential healthcare workers. And so here they would snow machine up to the plains and they would get vaccinated. They would wait 15 minutes and then they would fly to the next village and they could do 10 villages in a day doing all the community health workers. It was about -40 the days that they were doing a lot of this. They found that the vaccine froze in the needle really quickly. So they had them all pulled up in it. So that was like one thing we weren't totally prepared for. So they had to figure out how to like keep it in their jacket between the plane and the snow machine and like do it quickly and then like make sure they watch them. We had one of the first cases of anaphylaxis, and so this was all happening at the same time. So that was the other concern. So they traveled with a whole lot of epi and prepared to fly anyone out if they were having any adverse reaction. All the community health aides do have epi and know how to treat anaphylaxis too. So there was, a degree of comfort there, but it all went well. Other pictures, so the picture on the sled here, this was out of the Manilik region. It's actually being pulled by a snow machine, not dogs, unfortunately. But this was when they were doing 65 and older, and there were many communities, elders who could not come to a vaccine site. And so they use this is actually the school bus that they use to get kids sometimes to and from school, and they used it for the vaccine group. And they went home to home and just vaccinated all the elders home to home in the community and then moved on to the next community. And so this is a physician and 2 nurses and a pharmacist who were kind of the vaccine team in the Manilik region overall. Shipping is a huge part of this. We've had crazy pictures and stories of, on ferries and trying to get vaccine out there. Really super grateful for many of our small airline companies who have been a part of the vaccine process and have always been shipping vaccine for us for either free or for really reduced costs, but between all of these little villages. And they just all stood up and they were like, you tell us when and we'll fly and we'll go. And so I often get asked, like, how much is this all going to cost you? And I'm like, I don't really know, because many of these airlines are just like, we'll just do it. We'll just figure it out. So I know that's not necessarily a sustainable method, but it's working right now. And we're just really grateful for that partnership. You can see the snow machine and the sled there below. The picture with the woman holding the card, that's Dr. Ellen Hodges. She's the chief medical officer for the YK region. She just called me the night after first day of vaccinating in tears and said it was like the first moment of hope that she's had in a really long time. Her region's been hit super hard. They've had community members who have died in villages, unable to get them out and unable to get oxygen in, and has really just struggled. The Buy Next Now cards have been a game changer for that region, being able to get tests in a fast turnaround time. But they are on a mission. They've called it Operation Togo in reference to the dog who pulled the diphtheria toxin via the Iditarod. We have a long history of crazy immunization and protection in here. And so the 1918 pandemic looms large in the history of Alaskans, and the need to get vaccine, and in that case, toxoid out quickly. It really plays a role in the history here. And it's cool to see that same effort being repeated. Next slide, please. Here's some more fun pictures. These are community health aides. They found that if they did them in the plane, there was a little less freezing that went on. So they started to move some of them just kind of into the plane. They would come into the plane, watch them for 15 minutes and have them head on out. And here you can see groups taking out the vaccine in different regions around the state to be able to get it in different places. Next slide, please. Elders are a big part of our community in so many ways, and we initially struggled with kind of the age group, what we would prioritize. Our phase 1A includes everyone who is in healthcare, EMS. We really prioritize some of our life flight people just because we knew that getting people in and out of these communities was really important. So that was a super high priority for our processing. In 1B actually also includes like the small pilots and planes, just because as you can see, they're really important here. To being able to get, and a lot of people don't travel on medevac, they travel on commercial plane when they come out, if they're stable enough to get in and out. So they're a part of our medical transport regardless. We have one of the youngest populations per state, but we also have the lowest number of nursing home beds per capita. So we prioritize all of our nursing home in our December allocation. So all of December got a skilled nursing facility and long-term care. We've struggled, as I think many states have, with some of the federal partnerships in getting that out. We hear from CVS and Walgreens, like, it's hard to hire up there. It's a way distance. And we're like, yes, it is. We could have told you that from the beginning. So again, I think it's really important that we have a federal and state and local partnership with that and the private partnership. And so now that we've been able to be more involved in that, I think we've been able to help accelerate it. We have now opened up to 65 and older. That's been open since last Wednesday. Some real challenges there with calling and anxiety, just the amount of like fear, I think, in that age group of what COVID has meant. And then, they have an opportunity to get a vaccine and then they got to go through like a crazy website that they can't ever get to the end of, just is like overwhelming to many, many of them. So it kind of breaks my heart right now with how much of a struggle I've always said in emergency medicine, it's 5 clicks to crazy. And I feel like for many of our elders right now, they're experiencing that in so many ways. We have a call line. We'll schedule appointments for them. We're really trying to encourage communities to have call lines and to support them. I just got called yesterday by a recovery addiction support system, and they have 17 full-time people. And they said, Our elders have supported us through our addiction. We want to support them. So they're driving elders right now to their mass vaccine sites, and they're calling and doing all their appointments for them. So again, when you can get community to help support, I think it just goes much faster and smoother. I love this picture of this woman. She basically said that she was so excited to get the vaccine so that the big sickness wouldn't get her, is how she referred to it. And the priorities with the IHS allocation has really been very much in kind of the elder population. We've also prioritized native language speakers. Many of these communities, it's the elders who own and have the language, and there's some younger people who are trying to preserve that language. We saw with the 1918 pandemic that when it hit certain villages, entire languages were wiped out and entire cultures were wiped out. So the arts and the tradition, the culture really stopped at that point, and we've had 100 years of kind of grief and loss from that, and traumatic loss from that, and that historical trauma continues to play out. And so in an effort to try to prevent that and to learn from that in the past, we've really put an emphasis on that as well. Next slide, please. So those were some more slides. I think there's one more slide up here, but we really talk a lot about community in Alaska and what ways we can protect community, trying to just really emphasize that we're all in this together, and very Alaskan aspects. This is tough and this is hard. We talk a lot about vaccine in terms of winter. You know, we have a little bit of vaccine and we have a little bit of sun right now, but by spring equinox, we should have a lot more. And by summer solstice, hopefully it will be plentiful. And so I think when we talk about this in terms of other things that we're used to experiencing and relating up to here, it's really important. I really appreciate some changes that happened with the federal government's allocation. We were allowed to advocate for being a territory essentially and getting our allocation in a monthly allocation instead of a week by week. So if you look at our numbers, it always looks odd because we get these like big month and then we have to work through it the rest of the month. But it really helps us to overcome many of these geographic challenges to be able to get vaccine out. So that was a huge benefit to us, and I really appreciate that. I also think that the separate IHS allocation and treating our tribes as the sovereign nations that they are is hugely important. I think it's really resonated in the communities. I've gotten lots of comments of, you know, oftentimes we feel forgotten and lost, and we don't feel forgotten this time. So incredibly grateful for that partnership and moving things out as fast as we can. Next slide. So I think that is it. I'm happy to take any questions, but that's where we're at with Alaska and vaccination, and continue to be excited to get more out as soon as we get more in. February just feels like a long time away right now. That's the downside of doing month by month, but that's okay.
And I would have never imagined that Alaska would have the long-term memory on 1918. That just like blew, but the language thing that you described totally, I mean, I get it, but it's like never would have ever imagined that Alaska would have that kind of like anchored, no pun intended, anchored history with the pandemic. And yeah, the chat's got a lot of very grateful comments in there to your presentation. And I think it put a smile on a lot of people's faces, including mine. And we hear a lot of stuff on these rounds, so thank you. The one question I have, I'll turn it over to the panelists then. Also, just sort of like leaping forward and over the next half hour. I do have a few more polling questions than usual because I want to really drill down on where we are with vaccines across the country. So just sort of bear with that. And if participants can hang in there, maybe 5 minutes late to a meeting, that would be really helpful. So Ann, the question I have is like your, the anaphylaxis case that you alluded to, that one popped in the media, like it was like the first one, okay? Like boom. And it is totally predictable. And in many meetings I have here at HHS, but I know during the rounds, it is totally predictable. Somebody's going to die from this vaccine. I mean, it's going to happen. You know, just look at the sheer numbers. And somebody who got the vaccine is going to end up with the virus. I mean, it's like totally predictable. It's going to happen. So how did you, I mean, what was Alaska's reactivity to that anaphylaxis case? And you know, more than anything, I'm trying to get to, okay, what lessons or your observations that you can share with those participants that can help them when it does happen, because it's going to happen to them.
Yeah, and honestly, I was really grateful during that time of our Wuhan flight. So I don't know if you guys remember a long, long time ago now, but we were the state that had the first repatriation flight.
Yeah. Yeah.
And we had 72 hours to prepare for that and get through. And it felt similar in the sense of just immense anxiety and fear, and a lot of eyes watching and knowing something was going to happen, but how to manage that. I think what I learned from that experience is the human story is important and transparency is incredibly important. And the more transparent and timely you can be, the better off you are. So that evening, I think every ER doc in the state feels like they have my cell phone number. I got a text saying, hey, this is not going well. And this just happened. And so immediately able to kind of connect in and try to figure out what was happening, making sure the patient was okay. That patient ended up getting admitted to the hospital, required an epi drip. So when they would stop her on epi, she would start to flush up again and get short of breath. So it was pretty significant reaction. It wasn't just a, vasovagal, or I got some flushing or I got some hives. The hospitalist and the ED doc were pretty impressed at how severe that reaction was, which, clearly had me concerned as well. We're just starting to roll this out. I'm thinking about all these villages that I'm about to roll it out to. And I'm like, oh goodness, let's see how this goes. The CDC call line at that time was not 24/7. So you called and they said, it's off hours right now. And it doesn't help from the Alaska perspective when we're 4 hours off. And we were like, we've just got to make this transparent. So we held a press conference. We met internally multiple times that morning. And then we held a press conference at 10 a.m. That next day. That I think really helped in many ways, just immediately coming forward with it, saying, this is what we got, this is where we're at, we're prepared, this is what's happening. Really appreciate the CDC. Dr. Jay Butler joined us as well. And then, the local physician who took care of her was willing to join, and he was on. So he was in his little log cabin on, CNN as Jay Butler's on there and I'm on there, and people were able to ask all questions. And I think it just really emphasized that from the local provider to the state level to the federal level, we were all working together to be able to figure out what's best for patients and to learn from this and to be transparent. And I think that helped a lot. When I get feedback and stuff now, they're like, I saw that, but I also saw how you responded and we've gotten more information. I really think it's important that we don't hide those facts. We put them in context of what this means in an overall larger pandemic and the numbers, so we can kind of put those things together. And we just try to provide, facts as they are and science and information rather than shaming or not putting things out. So we did get, probably for the next week of, I'm not sure I want to get it because of X, Y, or Z. But I think now that many people are seeing it go out smoothly across the state in numerous places, they're like, oh, that was a small case in a bigger picture. And so I feel like the noise of that has settled down a lot since then. We have actually also gotten our allergists and immunologists. We do community calls where our team goes around kind of different communities and has these echoes. We use a lot of echo. And we've had an allergist and immunologist on those calls just to answer. But they've honestly, they're not getting much questions anymore. They got bombarded at the first, but it's really settled down significantly that I think people are kind of understanding. And again, the CDC's guidance, I think, has been, and how to treat anaphylaxis and what's on there, I think has also just provided another resource. So it's, I think, just transparency and acting faster than you ever think you need to. Like getting in, social media spreads so fast that rumors go fast. If you can get in front of it beforehand, if you can own the conversation instead of letting someone else own it, it changes the narrative for the next month. So that would be the other thing that I learned from that. Again.
Yeah, thanks, Ann. That actually very helpful. And also the human story piece. And what I saw in the photos and your description is that community engagement that it's extraordinary. Done with your community, large community. When you said about how large it was, I kept thinking about my flight. The first time I went on a flight from Seattle to Anchorage, and it's like, is this flight ever going to end? So I'm with you. I got it. I was going to only ask one question, but one question came up that kind of like follows on a little bit in terms of like getting ahead of things. Vaccine hesitancy is already there, but how are you working through that? And are you able to get ahead of that in any way?
Yeah, I'm concerned about it. So I think we have fairly low vaccine rates across most of our state. Our Alaska Native population has our highest vaccine rates in general. I think when you see and live with disease on a regular basis, you're much more likely to get vaccinated. And they've had some really bad struggles. You brought up the 1918. I mean, many of our hospitals are built. One of them was built in the orphanage from the 1918 pandemic. There's not a I can have in rural areas that does not bring up the 1918 pandemic. So I think that history in our rural areas, it makes a big difference. Our more urban or kind of more, I guess it's not really suburban, but like I think of like the Kenai Peninsula down in Homer, Matsu region, out by Tahkeetna, like those are really, really low immunization rates. And we are seeing a lot of hesitancy in that group. I think we're just giving it some space and grace in the sense that, we don't want to browbeat anyone. We are in a time of limited vaccine availability. And so we're getting it out to those who are interested. There's no guilt and shame of wanting more information. Like, that's never a wrong answer. And we want people to have the tools and resources that they need so they feel comfortable to make the decision for them. I don't think shaming ever works for public health. And so we've been just really mindful of that. And I think meeting people where they're at. People have different hesitancy for different reasons, and finding out what that looks like. I also think trust local people that they know or love or care about. And, it's been a little odd for me to suddenly be this like government official. I don't feel any different working in the government than I did when I, worked just in the ED, but I get that perception and what that looks like. And so we've been doing these kind of community-wide ones where we've been helping to facilitate it, but we're now starting those up. Done by just the local providers. I was on with Fairbanks the other night, and one of the providers was like, listen, we're fiercely independent. No one tells me what to do. And I generally don't believe in vaccines, but this is why I believe in this vaccine. And this is why I'm recommending it to my patients. So I think hearing from their direct providers like that on the reasonings behind it. And then we put a ton of time and effort into educating healthcare providers just so that they can empower their patients. And then I think some places, those relationships with the public health nurses who have lived there, worked there, for those who have good relationships in the community, help a lot as well. So just trying to continue to work down that process and just continue to encourage vaccines. But I would say the 65 and older, it's been an impressive uptake right now. I mean, we are not getting a lot of hesitancy. Our direct healthcare providers as well. And even in like the YK region, about 30% are kind of refusing vaccine right now. And many of them are coming back around and saying, oh, it went fine when you came to town. Like, everyone's still okay. Can I get it on there next time around? So I think as people get more comfortable with it, we'll start to see less hesitancy as well. So.
Yeah, you have actually really interesting insight. And I hadn't even thought about this before with, okay, because we don't have enough, those that want to get it are going to get it. And those vaccine hesitant people, the ones that are on the fence, have the opportunity to see that success. I had honestly had not a blind spot on that one. So thanks for that. I especially appreciate that insight. It's 12, I'm looking at 12:40 right now. And if the panelists can bear with me, I'm going to switch it up and go to the polls because I really want to get some insights from you as participants on what's going on out there. So there's a few more than usual. So just hang it in there. Some of them are really straightforward and some of them are a little bit more long, and I've tried to tune them up, but Amy and Amanda, if you can pull them up, that'd be great. Okay, this one's like pretty straightforward. This is like, you provide direct patient care. Which one of the following is true regarding vaccination? And we've been tracking this one over the past week and a half or so, past couple of weeks. And there's a NA not applicable because you don't provide patient care. So there's that option too. Another 5 more seconds. All right, let's stop there. Wow, great. It's like 64% of you voted. Thank you. Well, at least, looks like I received the first doses in the lead. At least we got that far. That's great. Okay. A lot of work to do, but all right, next. That's pretty similar to yesterday, I think, Bruce, in terms of that question. I think it's very similar. We did it on, was it yesterday? No, Tuesday's critical care rounds. We did the same question, and it's pretty similar, those responses. Another 5 seconds. All right, let's stop there. Looks like the lead is 50%, with 24% of the participants responding 50%. All right, that's quite a bell curve, actually. Thanks. Next. Sideways, like bell, but what the heck? Were EMS clinicians included in the first round of vaccines in your state? Another 5 seconds. Yeah, this is great. Thank you. Let's stop there. 69% of you voted. 72% said yes, 17% said no, 10% don't know. All right, next. All right, this is one, this one, yeah, there's a lot of options here, and I'm sure I missed some, but in my region, the following has been the greatest barrier to vaccinating the public. And so you only get one response, but there's like a lot of options there, so. And I ran out of options to put an other there, so my bad. All right, let's stop there. 62% voted. Yeah, there were a lot of options, so let's stop there. Looks like the most frequent response was to not enough vaccination product on hand. Let you all look at this for a minute. Other high frequency responses were scheduling appointments, distribution, site logistics, not enough staff to administer, vaccine hesitancy. But I'm actually, for me personally, I'm a little surprised that inaccurate information on social media wasn't higher. Same about not enough information shared with the public. That was pretty low too. All right, thanks. Next. The public in our region is being vaccinated at a pace much faster than expected, as expected, slower, and then much slower than expected. All right, let's stop there. 65% voted. Let you all view those results. I think we all got to learn from that much faster than expected participant there. All right, next. I have observed that the capability of older adults to make online appointments has been a barrier to their being vaccinated. Yes, no, don't know. Oh, a great conversation in the chat. Appreciate that. Another 5 seconds and we'll stop. All right, let's stop there. 64% of you voted. 44% indicated yes, 10% no, 46% said don't know. Okay. Give me just a second so people can take a look at it. All right, next. I have observed that the lack of broadband computer access has been a barrier to vaccinating the public. Wow, people are going so fast on this one, like lightning. All right, let's stop there. 61% voted. Yes, 21%, no, 29%, and 49% don't know. It's interesting, you know, my thought about the broadband and computer access is like, okay, there's the broadband and frontier areas and so forth, no access, but also computer access for low income families. So not just for the rural frontier for sure. All right, next. And there are two questions related to crisis care that are coming up and really would be helpful for you to answer these to get a handle on where we are today. We've done this specific question over the past couple weeks since the beginning of the year. Another 5 more seconds. I want to see if we can get as many responses to this one as we can. All right, let's stop there. Now, there were 28% of you, or no, 28 of you indicated yes. So those 28, hang on. The next question is for you, okay? The 28 that said yes. All right, let's go to the next question. All right, so those 28 of you who said yes, you already said at least one of your region's healthcare facilities or EMS agencies has implemented crisis care strategies. Now, have at least one jurisdictional authority in your region currently supporting implementation of crisis standards of care with a formal declaration.
So Rick, the main issue here is you're wanting people to highlight if they've had a formal declaration. as well as
Yeah.
informal implementation.
Yep. So, you know, number one, you're doing crisis care, and number two, and there's been a formal declaration by a jurisdictional authority. And Bruce, this gets back to one of the comments made by Laura yesterday about the formal declaration. I was trying to figure out how to get to that issue. And I did it separately. I had a separate question, like, okay, at least one jurisdictional authority, but then I had to couple the two. So that's why it's so long and convoluted. And Amanda and Amy, thank you for giving me the 3 extra characters to be able to get it all in there. All right, 5 more seconds. And let's stop there. Kind of an even split between yes and no. Roche, as we have the discussions with around crisis care without the work group that AAMC, Hospital Association, National Academies is involved with, that's the kind of information I want to make sure they are aware of. Crisis care without formal declarations is we got some real challenges right now. All right, thanks everybody. Really appreciate you all hanging in there for a lengthy polling process. I don't try to do that very often, but it's very, very informative. And I'm going to give you like the first comments based on what you saw there. You know, you talked about vaccination for a while. You saw those responses. Any immediate reactions to those?
It's really good to see what's happening. You know, I'm sad for our country, you know, seeing how many people are at crisis standards of care and where we're at overall. I think all of us know as clinicians that we might be making micro choices on crisis standards of care well before it's nationally called. And that has real health impacts. And there's many, many reasons to try to move out of this surge for all those aspects. So I don't know. I guess those are just kind of my initial thoughts, and thinking about that is just feeling sad for our country and hoping that we can get more. It was great to also see many other people say that vaccine limitation and scheduling were kind of their big barriers. I think that there's this national conversation that like somehow it's going really slow. I feel like running a marathon, and you know, it takes a minute out of the gate to just like get your speed up, right? To like, you know, do all those things. And I keep telling people, you know, we didn't know how well this would work in elderly, you know, until mid-December in some ways. So it was who we were going to prioritize, and that aspect took a long time. So I know people fully understand all of the logistics. If I wanted to vaccinate quickly, you know, 40-year-olds with a car in my urban areas would be super fast, but I want to make sure it's equitably done, and I want to make sure I'm decreasing morbidity and mortality. So, you know, we have our most complex groups like long-term care facilities and, you know, technology challenge elders in rural communities are who we're starting with. So no wonder it's slow. You know, I get to 20, like if they're, as long as they're not hesitant, it'll be fast. So it was good to see other states seeing that. So those are my initial thoughts.
Yeah, not exactly a good analogy, but you know, the Queen didn't get hers till this weekend, and the Pope got his last night, I think, or yesterday, I think. So you know, it took a little while. So let's see. That was a selling point for my mother at 93. Just to let you know, the Queen piece. All right, so let's start with Dan Gerard.
Oh, Dr. Zinke, outstanding presentation. 2 questions. Two questions. One has 2 parts. What did you do ahead of time in regards to healthcare providers to overcome their any hesitancy that they had in regards to vaccines? And then what did you learn from this process that you're going to change in the future for future issues, community-based issues, and even issues that affect healthcare providers? And then the second question that I have, are you having a shortage of vaccinators, and how are you dealing with that in your community? And again, great job. Thank you, doctor.
No, great questions overall. I think that, you know, what have I learned, what have I changed, and what's worked well are a little bit all the same question in some ways. I think when I look back, one of the things I'm most grateful for is the numerous echoes that we've set up. So we have a public echo every Wednesday. You know, we still have, 400, 500 people who put in questions, and it's been everything from testing to now it's vaccine. We have a vaccine echo. We have a healthcare echo every Thursday for healthcare providers. We have one every Tuesday night which kind of feels like therapy session / state grand rounds, and where people kind of process what's been happening. I hope that we continue that for public health well beyond COVID. And we have one for perinatal and other things. I think it's just been a really helpful way to all work together and learn. And so that's been one of the biggest things I think that we have done, and that has helped us when we moved into vaccine hesitancy. I think once the data started to come out, like once the New England Journal of Medicine articles started to come, I mean, we went from 40% saying they would get vaccinated to like 80, 90% saying they would get vaccinated. Docs want data, and if you have data, I push back on this on monoclonal antibodies all the time. I'm like, we need more studies, and if you have really good, robust studies, that is going to be my biggest driver to get my physicians to refer them in if this is a game changer. And these vaccines are game changers, and so data is key. And so I can convince and make systems and logistical ways to schedule I want, but if the data is not good, I'm not going to convince my docs in the same sort of way, and nurses and my other healthcare providers. So I want to just move that direction and be transparent about what we have and be able to kind of move. And then I would say that having vaccine is our biggest limitation, not vaccinators. So we have something called AK Respond, which licensed healthcare providers can register as a part of. It's part of our normal kind of disaster response. We've used them throughout this pandemic. A bunch of EMS got sick in one region. We called a bunch of EMS from another region. We went and served it. Right now, we're having a surge in one of our other areas. Like we need some more nurses and respiratory therapists. We called in, and we've been calling them in for kind of our larger mass vaccination clinics. Right now I have over 50,000 orders from providers willing to vaccinate this month, and we just can't give them vaccines. We don't have it. So in general, vaccinators are not our limiting factor. It is vaccine is our limiting factor.
Thanks, Ann. And Dan, Dave Gerstner.
Sorry, I have to leave for another conference right now, and
No
that
worries.
was truly amazing. Thank you very much. Absolutely awe-inspiring.
Ditto that. Harry, I thought you had to go to a code.
False alarm.
Okay, well, that's good for the patient and you and us. Go.
So Ann, even having lived in Alaska, your whole talk struck me, some of the cultural implications. You implied this in one, so there's two questions that kind of revolve around your unique public health situation there with small communities that are widespread. Was that part of where you might just go into a whole community and just vaccinate the whole community from top to bottom, independent of risk factors, and essentially give the entire community immunization and protection? Or did you follow that strictly through the normal protocol? And the other is, given early on in this, as I mentioned to you directly, the fishing and processing industry was such a huge vector for spread of this. Was there any thought about possibly somehow putting a ring around that industry with vaccination to protect the other population of Alaska in that fashion?
Yeah, thanks, Harry. Well, that's a raw nerve on that one. But yeah, so we did, the seafood world is a challenging one. We've spent, I know more about deep sea vessels than I ever thought I would in this response. We have had some outbreaks. We have a lot of health orders that require quarantine and isolation and testing and surveillance testing, and they're not super happy with a lot of that. It's by far our biggest interjurisdictional, where people move from place to place. And so we are working with Washington. Both us and Washington did prioritize them. We said Alaska residents, they said anyone. We made an exception for healthcare workers and educators. We intentionally did not make an exception for seafood workers in that for two reasons. One, our international and migratory workers start to come up in the spring. So we're hoping for more vaccine in the spring so that we can change that. But we didn't want them to be sending a bunch of people up here to get vaccinated in time, because they're a really organized industry and lobby in many, many ways. And so we wanted to make sure it was really mindful and that we were getting the biggest bang for the buck. So I do think that that's going to change as we get a little bit more vaccine in stock in store, and potentially one dose in Washington and one dose up here. And so we're working with Washington State on what that could potentially look like. Right now, it's really just like out in the deep sea, Bering Sea crab fishing, so they're not coming into our communities. But in the summer, it's salmon, where they're on land in communities, shopping. That's where that spread. So we've got a little bit of time before the salmon start to spawn. So I'm hoping for a lot more vaccine by them and to have them really vaccinated by that point. So part of it was just industry timing with those guys. If we had gotten vaccine at a different time, we would have had a totally different response just based on who comes up here. Regarding your other question about communities, we've had a lot of those conversations. It really depends on the size of the community. Again, that's where kind of the leeway, I think we're all seeing this, right? If we have a little bit of leeway between our tiers, if we give some grace and space between it, it's easier to move quickly. And so we've tried to make our tiers big enough that they can move quickly. And then the IHS additional allocation has allowed it. So, you know, like I was just on the phone with the CEO of Evolution Chain, who was like, I just want to vaccinate the whole town, but that doesn't follow your tiers. I'm like, I'm not going to come after you. Do what's right for your community. Like, number one. Number two, use the state for the ones the state says and use IHS for the other ones. Like, make it work. Like, if that is what works for your community, make it work. And it's going to look different for other ones. So I think having, you know, we, knock on wood, don't know of any vaccine that has been given to someone that we wouldn't have put in a tier or place. Everyone's either got wait lists or they're kind of working within their community so they can call people quickly in. And so I think that process, we have had 20 doses that went bad in a shipment to Ketchikan. So it was a really small shipment with a new packaging that we hadn't been used to. So we've reverted to our old packaging. But besides that, we don't know of any wasted doses that have happened anywhere in the state from any appointment, from any other part. So it's getting out there fairly quickly, and just being mindful of that. We just live in a really different, we all do, right? Like our communities all look different. And so I think we're just going to have to, we want vaccines in arms, and we're going to try to do the best we can, but it's not going to be perfect. And I think allowing that little bit of imperfection will allow us to move faster.
Thanks. Rosha?
Yeah, I guess that was actually going to be my question, because it's interesting when we talk to some WMC CEOs, AMC CEOs in the South particularly, you know, initially their governors had said 75 and over. And what they found is that there weren't very many folks in minority communities, particularly African-American, that were over 75, which is really sad. You see the disparity right away. So they have asked to decrease the age to 65 so that the unique issues in communities and being flexible enough to deal with it so you do reach health equity, I think is really important. So thank you. That was my question.
Yeah, it's a challenge, right? Like our urban areas are angry. Like, why are these rural areas getting more? Or I'm 70 and I've all these underlying health conditions. Why would my neighbor who's 65 and running marathons get to be put at the same thing? And I think I just keep trying to remind people, like, we'll get there. Like, you have other tools in the meantime. Everyone is important. I hate the term essential worker. Everyone's essential. And I keep trying to emphasize this isn't about importance. It's about, you know, logistics, ethics, and science to decrease morbidity and mortality, just like the ACIP talks about. So we say that like 500 times a day. I feel like that's what we're talking about.
Yeah, thanks. Bruce, any comments before we have the last word from Ann?
Just thank you, Ann. Really, really appreciated your joining us again, giving us the update on what's happening in Alaska. As you can see in the chat, there are many, many expressions of appreciation, and you've got a big cheering squad out there. So thanks for the inspiration, and take care and keep going.
Awesome. Well, thanks for having me back again. It's always good to see you all. I need to come more often because I just do learn from you all so much. And it's always great to hear what colleagues are doing across the country. And I'm always inspired by new and creative ways to do things as we're all trying our best in challenging times. So thanks.
And my take homes for this one, that image of that lady with that smile, you know, poster child for the world, as far as I'm concerned. But also, I mean, I think, you know, I think about this a lot, and you said it, you kind of have to take people where they're at and not try to push it because they're receiving something. It's not like the other way around. And I think that's a huge component of what I see as an extraordinary effort on you and everybody in Alaska's part. And to me, it's almost like if Alaska can do this well with it, with hope, others can too. And that's reflected in the chat by so many people. So with that, thanks to our participants, really helpful information and dialogue, but information in the polling and the dialogue in the chat is really great. Echo, always thanks. And panelists, thanks for coming back always. And hey, Ann, you just keep doing what you're doing. and take care. And hope to have you back. See how things see how things are rolling out as this evolves. So thanks everyone. See you on the next one. Bye.
Bye.